two beautiful countries in the world, India and Australia. This is eCritCare podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checo from India.
Welcome to eCritCare podcast. This is our episode number 102. And today I'm joined by my co-host, Dr. Jose Checo. So welcome, Dr. Checo.
Hi, Swapnil. Good evening. Things okay in Sydney?
Yeah, things are pretty good. Overall, staffing issues are a bit better now. And then overall acuity seems to be settling down. How's things in India?
It's been pretty cool. A little bit busy on occasions, but it's something we can handle.
Yeah, no, that's a good news. So as for today's episode, we decided to discuss recently published randomized controlled trial in New England Journal of Medicine around the use of fluid resuscitation in patients with acute pancreatitis. Now, this trial is quite interesting. It is called as Waterfall trial. We do know that there is a controversy still exists around how much fluid to use in acute pancreatitis, which fluid to use in acute pancreatitis, especially between mild, moderate, and severe pancreatitis. Do these patients really need IV fluid? Traditional practice, which was out there for last couple of decades, was whenever you get a patient with severe acute pancreatitis, they used to get central line, they used to get bolus of IV fluids and then a large maintenance fluids. And always the traditional, especially the surgical teaching was keep them full, because there was always a concern around acute pancreatitis has this inflammatory response which leads to third spacing or fluid losses, and that's why we need to be on the top with our fluid resuscitation strategies. As time has passed by, we did understand the fluid resuscitation paradigm quite better now, and I guess we become quite majored in our practices around fluid resuscitation in patients, not only just with acute pancreatitis, but overall critically ill patients who come through the door of ICU. Having said that, the ward practices around these illnesses have still remained somehow closer to the traditional practices. So on occasion, we do see some patients who go to the ward with acute pancreatitis. They are still on maintenance fluid of 125 to 250 mils per hour for first few 10 to 12 hours. And this traditional kind of practice was like to finish 1 liter of bag of saline initially in 2 hours, then 4 hours, then 6 hours and 8 hours, and in that kind of way. So this trial is quite useful in that way, because this trial tried to assess the efficacy of aggressive fluid resuscitation in patients with acute pancreatitis. Now, what's the kind of evidence out there before this trial was performed? And there are only a few small size randomized controlled trials out there which have provided very conflicting results. Now, there are two trials involving patients with severe pancreatitis showed that rapid fluid expansion was associated with decreased survival. And that has clearly helped us to change our practices in patients with severe acute pancreatitis in intensive care unit. Now, there was also a randomized controlled trial involving patients without baseline systemic inflammatory response syndrome or SIRS, who therefore had an initially low risk of moderate to severe disease, showed a quicker clinical improvement with vigorous hydration than with the moderate hydration. I guess the overall trial was quite low quality trial. And also over the period of time, we have moved away from using the terminology SIRS, and we try not to use this terminology anymore now. There is also a systematic review which was published, and also its quality is limited by heterogeneity and the overall quality of the studies which are included within the systematic review. And it showed a lower incidence of adverse events and lower mortality with moderate hydration than with aggressive hydration. And because of this kind of couple of trials and also this systematic review, people kind of swayed towards using more aggressive fluid resuscitation in patients with acute pancreatitis. So the Waterfall trial, which basically a short form for the early weight-based aggressive versus non-aggressive goal-directed fluid resuscitation in early phase of acute pancreatitis. And this is an open-label, multi-center randomized controlled trial which investigated the safety and efficacy of aggressive fluid resuscitation as compared with a moderate fluid resuscitation in diverse sample of patients with acute pancreatitis with a range of severity of the disease. So, Dr. Chacko, can you please walk us through the methodology and the results of this trial, please?
The Waterfall trial, as you mentioned, was a multi-center, open-label, parallel group, randomized controlled trial that enrolled patients from 18 centers in 4 countries. Most of the patients came from Spain. There were patients from Mexico, Italy, and from a center in India as well. Acute pancreatitis was diagnosed according to the revised Atlanta classification. And for inclusion in the study, patients were within 24 hours after the onset of pain and 8 hours or less since a confirmatory diagnosis of acute pancreatitis. They excluded patients who had moderate or severe disease, which included patients who met the criteria for moderately severe or severe disease at baseline with organ failure, including shock, respiratory, and renal failure. They excluded patients with heart failure based on the New York Heart Association functional class 2, 3, or 4. Patients with uncontrolled hypertension, electrical abnormalities were excluded. Patients who were deemed to have a life expectancy of less than a year were excluded. And so were patients with chronic pancreatitis, chronic renal failure, and decompensated cirrhosis. So what it all boils down to is they included patients with mild pancreatitis. So there were 2 arms in the study. The first arm was the aggressive resuscitation strategy, in which they used a bolus of lactated Ringer's solution of 20 mils per kilogram over a period of 2 hours, which was followed by an infusion of 3 mils per kilogram per hour. So that's Ringer's lactate solution in an average 70 kilogram patient. This will come to 1.5 liters bolus, and you continue with 700, approximately 200 mils per hour. So 1.5 liters bolus and 200 mils per hour roughly. That's what it comes to in the aggressive resuscitation group. Then the other group was the moderate resuscitation group, in whom they gave a bolus of 10 mils per kilogram over 2 hours if they were considered hypovolemic, followed by a maintenance infusion of 1.5 mils per kilogram per hour. So that will come down to 700 mils bolus if you take a typical 70 kilogram patient, 700 bolus followed by 100 mils per hour. So roughly half the aggressive strategy. Patients in both the groups had evaluation of their fluid status at 3 hours, followed by biochemical and physical assessments at 12 hours, 24 hours, 48, and 72 hours. And once they made this assessment, they made adjustments to the rate of fluid administration, and fluid administration was stopped if there was suspicion of fluid overload. Oral feeds were allowed at 12 hours if the pain intensity was less than 5 on a scale called the PAN-PROMIS scale, which is a relatively new scoring system which bases itself on a 7-item scale based on symptoms that cause the most discomfort, pain, and concern to the patients. So oral feeds allowed at 12 hours based on the PAN-PROMIS score, at which time fluid resuscitation was stopped if oral intake could be tolerated for more than 8 hours. But the earliest cessation of IV fluid was 20 hours after in the moderate resuscitation strategy group and 48 hours in the aggressive resuscitation strategy group. So 20 hours, 48 hours was a cutoff for cessation of IV fluids completely, provided they could take adequate oral intake. How did they calculate the sample size? The calculation was based on an anticipated incidence of progression to moderately severe or severe acute pancreatitis of 35%. So as I mentioned before, these were patients who had mild disease. They assumed that 35% among them would progress to moderate or severe disease. And they calculated a sample size of 744 based on this number of 35%, 372 patients in each group for 80% power to detect a between group difference of 10 percentage points between the two arms for a two-sided significance or alpha level of 0.05. And they very rightly planned for two interim analyses after 248 and 496 patients. And at the first interim analysis, the study was terminated early due to safety concerns arising out of possible fluid overload with the aggressive strategy. So what did they find? They had 122 patients in the aggressive resuscitation strategy group and 127 patients in the moderate resuscitation strategy group. Their baseline characteristics were well matched, except for a higher incidence of gallstone pancreatitis in the aggressive resuscitation arm. Fluid administered during the first 48 hours, obviously much higher with the aggressive strategy, 7.8 liters median at 48 hours in the aggressive group compared to 5.5 liters in the moderate strategy arm. So the volume of fluid administered in the first 48 hours was considerably more, as you would expect, because the rate of administration was almost twice as much. They diagnosed fluid overload based on fairly reliable criteria. They did not use dubious clinical criteria. They were very clear-cut criteria to diagnose fluid overload. And they went by the clinical symptoms, signs, as well as radiographic evidence. And they used these criteria to diagnose fluid overload. Mild fluid overload, if it was responsive to medical therapy or a decrease of hydration, and if the PF ratio never dropped to below 300. So that was mild fluid overload. Moderate fluid overload was if it was responsive to medical therapy or decreased hydration, but the PF ratio was less than 300 at least once. Severe fluid overload was if the fluid overload led to mechanical ventilation or requirement for hemofiltration. So the outcomes that they looked at, the primary outcome was, as I mentioned, the incidence of moderately severe or severe acute pancreatitis. So these are all patients with mild pancreatitis. Progression to moderately severe or severe acute pancreatitis occurred in 22.1% of patients with the aggressive strategy compared to 17.3% in the moderate strategy. Although this looks like very different with a fairly high number of patients who progressed to moderate or severe disease in the aggressive strategy group, it was not statistically significant. So was the case with organ failures. Again, numerically much higher. Aggressive strategy 7.4% compared to 3.9% in the moderate strategy arm. Local complications, persisting organ failure, these were all higher but not statistically significant with the aggressive strategy. Respiratory failure, necrotizing pancreatitis, need for ICU admission, hospital length of stay, and the PAN promise score that I referred to earlier, these were all significantly worse in patients who had an aggressive strategy, but again, not statistically significant. But when they looked at fluid overload, the degree of fluid overload was much higher with the aggressive strategy, 20.5% versus 6.3% in the aggressive versus moderate strategy. This was statistically significant, risk ratio of 2.85 and a confidence interval of 1.36 to 5.94, suggesting significance. Fluid overload with symptoms was again higher with aggressive resuscitation, 18 versus 7.9%. Fluid overload with signs, 26.2 versus 11%. Moderate to severe overload, 4.9 versus 0.8%. So all this points towards a fairly high degree of fluid overload in patients who underwent a aggressive resuscitative strategy. And overall, if you look at their cohort, from what I could gather, only one patient required mechanical ventilation. So obviously, these were all patients who had mild disease, and some of them showed, a significant number of them revealed signs of fluid overload with the aggressive strategy. So that's the bottom line. Although the primary outcome of progression to moderately severe or severe pancreatitis was not statistically significant, the organ failures were also worse off with aggressive strategy, but not statistically significant. there were definite signs of fluid overload in the aggressive strategy group.
Thanks, Dr. Chakor. So I guess this trial is, as I said, interesting. This trial has clearly given us a definitive answer that aggressive fluid resuscitation strategy is very harmful in patients with mild acute pancreatitis. Obviously, this trial has not given us any answer around what should we do with acute severe pancreatitis. Having said that, I guess this trial has clearly challenged the dogma, and also probably for future, it will change the practices, especially in the ward setting, around the use of fluid in acute pancreatitis. This trial obviously comes with lots of limitations. Obviously, it's an open label, randomized controlled trial, so the internal validity itself questionable. This trial was stopped early due to futility, and I guess that clearly makes this trial even more underpowered. Now, there are a lot of things with regards to the design of the trial. Like, first and foremost, they compared the aggressive fluid resuscitation strategy versus moderate resuscitation strategy. Now, when you look at the moderate resuscitation strategy arm, the patients received on an average 5.5 liters fluid in first for 24 to 48 hours, which is still a lot of fluid. And now if you think about how much fluid aggressive fluid resuscitation arm received, that's a lot. So perhaps you might question whether they were too aggressive in their approach to give fluid resuscitation in aggressive treatment strategy arm. And perhaps that we definitely need to even question. And it would have been much beneficial if the trial had a third arm, which is either a restrictive fluid arm or probably no fluid arm. And if they would have compared these three different arms, or aggressive fluid resuscitation practices versus no fluid resuscitation practices, or minimal fluid resuscitation practices, then obviously we would have had an even much better signal to guide our practices in future. That's the major problem. And also, authors mandated to give the fluid in either moderate resuscitation volume or aggressive resuscitation volume for 48 hours. Now, often the current practice all over the world is, if you really don't need fluid, you don't give fluid. And also, we de-escalate our fluid treatments very quickly nowadays. So within this trial, there was this kind of protocol or dogma, which is quite surprising to me. Now, the trial was conducted in Mexico, Spain, and one hospital in India, which probably limits its external validity and generalizability of the results, I guess. Having said that, the whole hypothesis itself is questionable. And really, do we need to even think about doing another trial where we are going to compare giving fluid in with a bucket to these patients? So the answer to that is clearly no. And I guess this trial will definitely change practice in some parts of the world, or some developing world ICUs where these practices are still prevalent within the ward settings. But obviously, this probably won't change any major practices in most of the developed countries, where the fluid practices have already evolved over the period of time. So that's the kind of my main takeaways or main analysis of this trial. What's your thoughts?
It's interesting that you mentioned a possible third arm to the study with no resuscitation, like the FEAST trial. Perhaps they could have done that, because if you look at the inclusion criteria, these were patients who had no shock, no renal failure, no respiratory failure. And you would ask the question as to why would they require so much of fluid in excess of 4 to 5 liters in either arm? Is that really required? And predictably, they ended up with fluid overload. So that is pretty much predictable. And I think over the years, we have realized, not only in acute pancreatitis, but in general, in sick patients, if you try to resuscitate them with too much fluid, you're going to probably cause more harm than good. And that is, I think, quite evident from this study as well. So at least in our practice, patients with essentially mild acute pancreatitis, they would eat and drink if that is possible. And we would give IV fluids only if they are not able to eat and drink adequately to sustain nutrition because of pain or vomiting. In that case, of course, it's understandable to use intravenous fluids to support them. But otherwise, we wouldn't particularly consider resuscitating them with a bolus and running a high-dose infusion in patients with no evidence of organ failure. That's one of the problems. And secondly, these patients did not have much comorbidities at baseline. They were all patients with comorbidities were all excluded, including heart failure, hypertension, electrolyte abnormalities, and so on. So essentially, very stable patients at baseline who had mild disease. And the whole question is, why would they require resuscitation continued by a continued intravenous maintenance of up to 200 mils per hour?
I agree. And I guess it's similar to FEAST trial. This trial is quite useful to guide our practices in future. Now, obviously, with the FEAST trial, there were a lot of ethical challenges to even do the trial. Similarly, I'm pretty sure this trial to get through ethics committee would have been quite challenging, because we are trying to give fluid in abundance to patients who are not hypovolemic. So if you look at even the primary comparison between the two groups at the baseline, only 50% of the patient in each arm had some indication of hypovolemia. That means half of the patients did not have any evidence of hypovolemia, and we still end up in giving so much of fluid in this study, which probably doesn't make sense to start with. As you rightly mentioned, these patients, most of the times, they are in the ward setting. They will probably commence their oral intake within 12 to 24 hours. And then usually they will be just kept monitored in ward settings till they get better. And then obviously they will discharge without any major interventions, as the management is purely supportive. Now, nutrition support in these patients was interesting, because as per the table, only 7 patients in aggressive arm versus 5 patients in moderate resuscitation arm received some nutritional support, which again, it makes me wonder that these patients might have looked probably deceptively well, but they didn't get fed because they were on IV fluid. So this probably trial does not reflect the practices that we follow here in Australia and New Zealand. But I guess similar to FEAST trial, as FEAST trial helped developing countries and especially African continent to change their practices of not giving albumin boluses in patients with malaria. Similarly, I think this trial will help to stop these practices if they're still existing in some of the parts of the world. In that regard, this trial is really good and has informed our future practice of fluid resuscitation in patients with acute pancreatitis.
The authors mentioned in the introduction that one of the reasons why you might require aggressive fluid resuscitation in pancreatitis, even without shock, is because of a possible lack of perfusion to the pancreas and a higher incidence of pancreatic necrosis. So that is the putative reason as to why you would require excess fluid. But this study fairly conclusively proves that an aggressive strategy of resuscitation in acute pancreatitis, in mild acute pancreatitis, would certainly lead to harmful effects from fluid overload. It's a completely different matter when it comes to moderate or severe acute pancreatitis. There, of course, you would treat them with in a much more aggressive fashion.
Yeah, thanks, Dr. Chacko. So, as I said, probably it won't change my practices, but as I said, it will be definitely useful for some parts of the world where these patients are still managed by surgeons or less experienced colleagues in the ward settings. So again, this trial is good from those point of view. So thanks to authors for completing a very good randomized controlled trial. Probably the design could have been a bit better, but at least, as I said, it will help to change the practice around the globe. Thanks, Dr. Chacko. Thanks for your time. We'll be back in fortnight's time with another episode. Till then, goodbye and have a nice time.
Thanks, Swapnil. Thanks, everyone, for listening in. We'll talk to you next time. Bye-bye.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.